this final part of the module, we're going to discuss fraud and documentation and some key takeaways moving forward. So the first case that we'll look at with fraud in medical billing is related to upcoding or inflating the severity of the patient. So thinking back to those major complications and comorbidities, you basically say, hey, look, these patients were a lot sicker than they actually were, so we're going to get paid more. So this is a case that was settled in 2025. Seoul Medical Group, which is located in California, and this one individual, Dr. Cha, submitted diagnoses for 2 severe spinal conditions, so basically adding additional complications and comorbidities to patients who did not suffer from either of these. So they had all of these patients, and they basically just one after another were saying, yep, they all have spinal enthesopy and sacroiliitis. Sacroiliitis? Not my field. All right. When they were questioned about that, and basically said, hey, it looks like there's some irregularities. Do they actually have these conditions? They enlisted a third party, Renaissance Imaging Medical Associates, to generate a bunch of fake radiology reports, which turned out to be all identical, and submitted them to say, yep, look, they had this condition. But, like, surprise, surprise, suddenly you come up with a whole bunch of identical radiology reports for all these patients. Like, yeah, no. And didn't go to trial. Again, that's why it says allegedly, because they, haven't actually nobody was convicted. But Seoul Medical Group and Dr. Cha agreed to pay $62 million in penalties to settle this matter. And I think the personal penalty from Dr. Cha was like $4 or $5 million. So pretty big case. Another recent case from 2022 involved a PA, Colby Edward Joyner. This was in North Carolina, which relates to falsifying medical records to order unnecessary tests. So basically, generating fake medical records or fraudulent prescriptions for genomic and pharmacogenetic testing for Medicare beneficiaries. Had never met them, never seen them, never treated them. Basically just sort of called and tried to generate these prescriptions. And he was working as basically an independent contractor and was getting paid per prescription that he generated. So pretty clear, just creating work for himself so that he could get paid for all these. And he is currently in prison. So these things are taken very seriously, especially when the government's on the hook for them. So, if you are in that sort of leadership role or supervising others or overviewing your organization's CDI and documentation policies, some red flags to look out for. One, new diagnoses appearing only in coding reviews, not in the clinical notes. So, that's where we get into those non-compliant queries. So, we're basically trying to upcode, bill a bunch more in the query coming from the organization or somebody in billing and not from the provider and their interaction with the patient, right? Pressure to find additional chronic conditions, hey, go back and see, can you increase the severity of this? Can we move from, that low complexity medical decision making up to a medium or a high complexity medical decision making to increase the relative weight of the CPT code so that we can bill more for it, right? Cut and paste radiology reports, identical chart notes. If you're seeing the same thing over and over again, hey, that's probably a problem. Now, this isn't saying don't use dot phrases. Those are fine as long as you actually did those things, right? It's just where you're just taking the same thing, pasting it for all your patients, especially if it's related to diagnoses that you're then going to bill for. Procedures listed without matching exam findings or diagnoses without clinical data. Again, basically, we're at the end, we're trying to tack a bunch of stuff on. That's probably going to be a red flag and could get caught in auditing. And then overuse of high-paying codes. So that's kind of what we saw in that first case with the upcoding. Everybody knows that there's going to be some fairly sick patients, and there's going to be some people that need a lot of work and need some expensive procedures. But when a disproportionate percentage of your patients compared to similar providers have those high paying codes, it's going to cause some red flags. Okay, so moving on from issues of fraud, let's talk about measurement and importance of the revenue cycle. So, we've talked about all this thing. Where does the revenue come from? The sources of revenue, making sure it's documented accurately, all those things. But how are we measuring it, and what's the organization going to consider? All right, so organizations are going to look at many different metrics to examine different parts of their revenue cycle. And the way to think about this is like your car, assuming you still drive an internal combustion engine car. Right, you're going to have a bunch of different indicators on your dashboard. So you've got the speedometer, obviously, how fast are you going, but you also have the tachometer, how many revolutions per minute is the engine spinning at, the oil temperature, the engine temperature, the oil pressure, the voltage of the battery, the miles per gallon, all of these things that are measuring your engine performance and the vehicle performance. And they all have to be, in that sweet spot, or you're going to have issues. So the same thing for an organization. So we want all of these different metrics to be in the right spot. And any one of these potentially could cause long-term issues for the business in terms of financial viability, being sustainable, staying in the black. So the first is days in net accounts receivable. So this is the number of days required to collect on charges for the care provided to patients. So from the moment that we have provided all of the care, we've earned that money, right? So think about, if it's easier, think about yourself maybe in private practice, right? So taking care of an individual patient, you have a private practice, you've earned every penny, there's no more work that you have to do, right? Now you're just waiting to get paid. And the longer that delay, the more difficult it is. We all want to get paid faster than slower, right? And this is an older paper. This is 2008, but I think the finding probably still holds true today. What they found is that organizations that had more days in net accounts receivable, so the longer it took them to complete the billing, the lower their billing was in terms of percentage. So basically, they were less effective at billing and collected less revenue for the same amount of patient care. And it kind of makes sense. Like the longer there's a delay, the more likely something gets missed, or you're not able to complete a provider query, or whatever the case is. So we want to close that loop. The next few metrics relate to the amount of money collected. So net patient revenue per adjusted discharge. So how much are you getting paid per patient? After adjusting for all these different things. So all else being equal, you'd rather get paid more than less, right? The contractual allowance percentage, this is not something that you can impact day to day. This is impacted in the negotiation process between the hospital and the payers, or the system and the payers. So think about when you have mHealth is negotiating with United Healthcare for these different services. We saw that the charge, that's sort of the opening for negotiation, is going to be $500 for fixing a simple laceration. And different payers are going to be charged different amounts, right? So as the system, you would rather not have to give much of a discount, and you'd rather get, have your contractual allowance percentage be much lower, so you're charging the full price to as many people as you can. The flip side of that's going to be sort of the charity care percentage. We all, I think, would love our organizations to be providing charity care to folks who don't have insurance or are underinsured. So what percentage of that gross patient revenue is provided as charity care, where upfront, we're not going to get paid for that, and that's okay. For some of those patients, especially if you're in an ED setting, EMTALA requires organizations to provide medical care to anybody who shows up at the door of the ED, and so we know right off the bat we're going to be providing a lot of that as charity care. We're never going to be reimbursed for that. So, how do you handle that? Well, it's a tough question, right? Like, on the one hand, we want to help as many people as we can, but the organization has costs and has to cover its costs, or they've got to close the doors. And that's just the reality of it. So you have to, that number has to be a sustainable number for the organization, and it has to be covered by all of the other patients that you are able to bill for, right? So it's just an important thing to be aware of, and then figuring out, okay, this is how much charity care we're going to have to provide, again, patients showing up at the ED, or that we'd like to be able to provide for our underinsured patients. And so how are we going to cover that and incorporate that? Maybe that's through fundraising, maybe that's through, hey, these are the prices we charge. We're going to charge patients who can afford it a little bit more so that we can provide this care, right? And then finally, bad debt percentage. So percentage of gross patient revenue that is written off as bad debt. So this is not upfront provided as charity care. Patient has coverage, but maybe they're underinsured, and so they have a balance due and they're not able to pay it. And eventually we're just going to write that off and say, we know we're never going to get paid for it. This is a tough issue, and there's a lot of debate about what should happen with medical debt. Should it be able to show up on credit reports? Can organizations deny people care for it? I don't have a great solution. We'd love everybody to have universal coverage and for this to not be a problem. But again, from the perspective of financial management of the organization, you can't have too much of your revenue. You expect I'm going to get paid this much, and then you never get paid for that. You just can't run an organization that way. And again, think about it from like a personal perspective. If you keep going to work and they don't send you a paycheck, eventually you're going to stop going to work, right? Same thing, because you've got to feed your family. You've got to pay the bills. And healthcare organizations are no different. And we do see organizations end up closing when they're not able to sustain themselves financially. So these are the types of metrics that we look at, and try and identify, well, which ones of these can we adjust to keep the organization in the black, to keep things where they need to be. Okay, so let's just wrap this up. I know this was a long module, not the most interesting stuff, but let's sort of wrap it up. First, revenue management is an incredibly complex topic, okay? There's whole textbooks, so I read this one in particular and a couple other resources as I was preparing this lecture, things like I'm familiar with, but I'll be the first to admit I'm not a billing and coding expert. I'm so glad I don't have to do billing and coding day to day. There's a lot out there. It's going to be very specific to your organization, and what you really dig into and what you really care about is going to be specific to where you're working. And most of this you don't need to memorize. You don't need to know every in and out of every little thing, but you've got to figure out, what do I care about and what affects me and my job and my organization, because you may find that there are really, really nitpicky details that make or break it for your organization. And so understanding where the revenue comes from, the technicalities of how that revenue is calculated, that's going to tell you where are the levers and the buttons that I can push to make sure that we are where we want to be. So there's a lot of resources out there. Again, AHIMA, American Health Information Management Association, they sort of offer all the training standards and all the resources. So these are some of the certifications that you might see like billing and coding experts have, and sources of education, all those things. Do I recommend a clinician go get one of these certifications? Probably not. But this is sort of what's out there, and figuring out who's running this for my organization. Do they have the training? Do they have the knowledge? I worked at one place in particular where we didn't have anybody who had this knowledge. Billing was very much like ad hoc, sort of done by, this was an EMS, which is notably chaotic with billing. It was sort of done by EMTs, like quote unquote, in their spare time. It did not go well. We were years behind in billing, and we're only collecting, a fraction of the revenue that we should have been, from patients who had insurance, who had good insurance. A lot of Medicare patients, for example, they had good coverage, and the organization really should have been reimbursed for that and was not financially sustainable. Just in a bad spot. We weren't able to get new trucks. We weren't able to do what we needed to do. And fortunately, they hired some folks with these types of certifications who had the knowledge and were able to to get things back on track. So yeah, all that's to say, who has that knowledge and knows that for your organization? Can you work with them to figure out what needs to happen? And so this kind of leads to a big practice management decision, especially if you are working for a smaller practice. So the question is, should your organization do your own billing and coding, or should you outsource it to a third party? So everybody knows how complicated this is. The software is very complex. It has to be updated. And a lot of the processes that go from taking your clinical notes, maybe the diagnosis, and turning that into a billable CPT code or DRG or whatever, depending on the setting, it takes a lot of specialty knowledge. And maybe your practice just doesn't have the staff or resources to do that. And even large organizations say, you know what, we don't want to run our own billing and coding. We're going to outsource it to a third party. And typically this is done for a fee of around 2.5%. A lot of the major EHR, at least for private practice, the smaller EHR vendors also offer all the billing and coding. They have the billing and coding modules, and they'll have all the people do all that stuff. They'll do all the queries and everything and send that back to you and submit all of those things for you. So they would sort of sit in between your organization and the clearinghouse. So you submit everything through your EHR, practice management software, that goes to the vendor. They do all the billing and coding. They submit it to the clearinghouse and the payers, and you get paid. So there's a lot of reasons to believe that maybe this is better off. For our practice, we don't have to hire those people, make sure they know what they're doing, supervise them, make sure we're staying compliant, all those things. We can outsource it to a much larger organization who's doing this for thousands of practices nationwide, and they're able to then make sure they get it right. So it's an important decision. So what's the bottom line from all this? Is this something you're going to deal with on a day-to-day basis? Maybe, maybe not. I think what's important to take away is that understanding and working with the revenue cycle instead of fighting against it can reduce your workload. If you understand why do they keep coming back with queries. Okay, well, I'm gonna adjust what I'm doing, or I'm gonna say, hey, we should get an AI tool to help us make sure we're writing these the way they need to be written to reduce the workload, to reduce the admin headaches for your patients. So as the billing gets done right the first time, so that all that goes through for them. They hit their out-of-pocket max earlier in when they're expecting it, whatever the case is, right? And ultimately help keep the organization financially solvent so that you can do what you really want to do instead of dealing with constant financial crises. Okay, so what does that mean for you? Like, what are the concrete things that you as a PA can do? So again, this is from the oncology setting, but these recommendations, I think, translate across clinical specialties. So the number one recommendation is to understand the language of productivity and value. So like we pulled up in the clinical documentation section, AHIMA is recommending to billing and coding folks that they look at what percentage of queries are being answered by providers. Okay, so understanding what leadership and management are looking at about how you do your job. It's necessary for you to be able to be on even footing with them to have that conversation. So understand the language of productivity and value that is being used around you, whether you like it or not. Take an active role in the business operations. Don't just say, well, I'm not going to be involved in that. To advocate for you, for your peers, for your patients, you've got to be involved in that conversation. Getting to know the coders and office managers, more applicable probably to smaller practices, but could be relevant, for a lot of folks. As appropriate, asking for feedback on how to improve clinical documentation. Maybe the flip side, as you get, you're going to be probably more experienced, guiding and mentoring those new PAs to make sure that they, because I keep getting it kicked back. Like, all right, well, here's why, man. Like, here's how you fix that to take that off your plate. right? Again, we don't have to like it, but we're probably going to lose that battle if we try and fight it. So, all right, sure, I'll concede on this one. I'll write whatever you want to write, and I'll take care of my patients the right way. I like this. This, again, not my words. This is from Table 2 in this publication. Understand that politics plays a role. Okay, this is not cut and dry. Sure, a lot of the regulations are. The formula for calculating reimbursement is, but then what does your organization do with that in terms of how the organization runs and how they treat PAs? That's political, right? Because it's among people, and it's not dictated in law or regulations. Politics come into it. So, just understand that. Then a big one that comes up a lot for PAs, understand, what the organization is seeing in terms of the productivity. So we saw, Hennepin Healthcare and lots of other hospitals, they're reporting the number of WRVUs in their financial statement. Okay, so if they're reporting that, that means senior leadership is looking at that. We know, we don't have to guess like, well, maybe senior leadership looks at those numbers. They are 100% looking at WRVUs. Okay, so understand that they're looking at these types of dashboards and productivity measures. How are they using that to evaluate you? Now, hopefully they're taking a good holistic view, but that may not always be the case, okay? So understand, what are the types of things that you do that don't generate any WRVUs. I recently had a minor surgical procedure. All my pre-op and all my post-op stuff was with a PA. And it was, the surgeon who did the actual surgery. And, I know that, and she was great. She did a great job. Everything went fine, super easy. It was a great experience from the patient perspective. But, in the back of my mind, I'm like, on paper, you had a big 0 next to this, 20 minutes that you spent with me, in terms of WRVUs. She did everything right. She did a great job taking care of me as a patient. But if you look at that particular metric, she got 0. Is that fair? No, probably not. So we need to make sure that other things are being considered. Call schedules, maybe just hours. Like how many hours of face-to-face time with patients is there? Because that's value add to the organization, to the patient. So, and not necessarily captured in WRVUs. So are we looking at the right metrics? Okay. Asking to see what are the metrics that management's looking at. So asking to see these monthly productivity reports and being prepared to discuss them. So what is reflected in those and what maybe isn't, okay? And then if your work is not being reflected in the metrics, think about, hey, are there other metrics that we can include? This last one, I'm not one to try and encourage dissent or disharmony, but are PAs and NPs being held to a different standard than physicians unnecessarily? Like the role is different a lot of places, and then the responsibilities are different. But if we're holding one set of folks to a certain standard, is another set of individuals not being held to that same standard? And if not, why not, right? Maybe there's a good reason for that, but if there's not, let's look at that. So again, not my recommendation necessarily, but I don't disagree with it. And so you've got the citation there of like, hey, this is something that could be worth doing. All right, so final questions for you as you take this forward. Are you able to answer these questions? And maybe things to look at as you dig into, the organization over the next months and years. Where does revenue come from in your specific practice? So maybe that I understand why we're a 340B hospital. That's why they want me to send folks to the hospital pharmacy. And so all else being equal, yeah, send them to the hospital pharmacy. No skin off your back. If your patient's fine with that, send them to the hospital pharmacy as long as it's as long as everybody's okay with it. Then the hospital gets the 340B revenue. And if the choice is between Walgreens making a little more money and your hospital getting some 340B money that they can use to do some charity care, I know which one I would pick, right? And I'm not gonna I'm not going to chafe at leadership when they say, hey, we'd like you if you can. If the patient says, oh, I don't have a preference, then maybe just say, hey, what about the hospital pharmacy? It's right here. Instead of saying, oh, well, what's your closest Walgreens, right? If the patient says, hey, this is my preferred pharmacy, absolutely, send it wherever the patient wants, and they can always transfer it later. But all else being equal, maybe that's a suggestion. You say, okay, you know what, that I'll get on board with that suggestion. Sure. How does the revenue cycle impact your daily practice as a PA? So what types of things are you asked to do that impact the revenue cycle, and where do you have the opportunity to impact that? So maybe it's saying, okay, I'm going to make sure I prioritize getting my CDI queries done so that we can, get that billing done and get those folks off my back, right? And then last, how does the revenue cycle relate to how you will train or manage PAs? I know a lot of us, even at the EMT level, like we chafe at anything that's not related to patient care. Like, I want to do patient care. I want to do my job. I don't want to do all this billing stuff. I mean, I know and at the EMT level too, we'd get, you'd log into the system when you start your shift and you'd get this like notification, like you have queries you have to answer. Like, geez. Like, that was the worst part of my job. Like, and I don't have time for this right now. I'm starting my shift. I got to do my truck check. I got to, and we got a bunch of, calls already. Like, we got to go. I don't want to do this, but okay, I will make sure I get them done at the end of my, shift before I leave today. And training new folks, the importance of that, hey, this isn't something you should let go. This is something to prioritize. So making sure everybody knows that, and making sure, young PAs in particular, maybe understand how they're being judged. What are the things that you'd make sure that the folks you're training understand. All right, so long module, but important stuff. And hope you enjoyed it, and we'll see you next time.